So this abstract that we're presenting about Glofitamab and how best to mitigate the main concerning side effect of cytokine release syndrome. Again, CRS occurs in most patients with bispecific antibodies. Mostly it is low grade. So we shouldn't be too concerned about just the word CRS. Grade 1 CRS is just a fever. Most of us got grade 1 CRS after our COVID vaccines. We just don't call it CRS in that case, but not the end of the world. Grade 2 CRS, fever plus some degree of low blood pressure, but low blood pressure we can usually treat with just some IV fluids. So enough that you probably would want to be, around medical care, maybe hospitalized for that. And then grade 3 is really where we start to worry about these patients. This is hypotension that requires pressors, or sometimes hypoxia require more aggressive therapy, but mostly fever plus hypotension. And so grade 3 CRS has been overall low with the bispecifics, usually 3%-ish, but the Glofitamab phase 2 trial, 150 patients treated, we got to get some hints of the best ways to prophylax to prevent the higher grade CRS. And one of the hints was, of course, to do, we say, step-up dosing instead of starting at the full dose, working the way up, 2.5 milligrams, 10 milligrams, 30 milligrams, and that already seemed to mitigate the CRS quite a bit. But we give prophylactic steroids. In the beginning, it was unknown what might be the optimal steroid regimen, Prednisone versus Dexamethasone. So not truly randomized, but we got to look at some cohorts getting the different approaches. And the Dexamethasone prophylaxed patients did much better in terms of CRS. When we look at these, again, non-randomized cohorts, it was almost half the incidence of CRS in total, and certainly the grade 2 and above CRS instances were greatly reduced. So this is the go-forward recipe for Glofitamab, and probably other bispecifics in this space will have to probably take lessons from the great work done here in the Glofitamab trial, because it is not absolutely the go-forward recipe for other bispecifics, but probably it should become a consideration for all bispecifics in this space. Dexamethasone, much lower rates of CRS, and just makes the whole therapy much more doable, especially in a community oncology practice where it is a little harder to take care of these patients in the hospital. So a very meaningful observation, and will probably impact our patients getting bispecifics going forward.